So we have the tram tracking appearance, the nematosis intestinalis, which is typically the picture seen in stage 2 NEC. So necrotizing enterocolitis is acute and potentially serious gut condition which affects mainly the premature babies. It can be seen in some term babies, especially those who are exposed to hypoxia, ischemia. Remember, this can happen within the uterine stay as well. So the baby may become symptomatic even within a few days of birth if it happens in a term baby, because ischemic injury is either at or before birth. In a premature baby, the timing is according to the gestational age. The more premature the baby, the later the onset. If it's a 24-25 weeker, we expect after 3 weeks. If it's a 32 weeker, it might happen by 10 to 14 days. The feeding pattern is important. How successful we were, whether we had EBM, severity of the underlying conditions. So this baby had a tension pneumothorax, which could have led to a hypotensive insult. The baby had sepsis as well. If you don't give EBM or you're adding human milk fortifier, which increases the osmolarity of the feeds, it might contribute. Antenatal steroids are protective, as we discussed earlier. This we discussed already. The management is by keeping the baby off the feeds, giving TPN during that period, antibiotics as appropriate and titrate it, rationalize it according to your culture reports, surgical intervention as appropriate as well. So if it is a severe NEC with fixed bowel loop, perforation and so on, laparotomy with exploration is important. Some of these babies are very tiny, they are very poor risk for surgery. And in that case, the surgeon may decide to put a simple drain and review. These babies may still need laparotomy once the baby is clinically more stable. We have something called the Bell staging or modified Bell staging for NEC. So stage 1 is suspected NEC. Most of the epidemiologic data now don't include stage 1 because it's very non-specific, and this feature can be present with any deterioration, sepsis, for example. If there is bloody stool, it goes more in favor of NEC. And on X-ray, you may find dilatation, non-specific dilatation and mild ileus. Again, ileus could happen with sepsis as well. Stage 2 is proven neck, and we have the stage 1 findings plus metabolic acidosis, thrombocytopenia. The bowel becomes sluggish, and there may be abdominal tenderness and redness of the abdominal wall. We get intestinal dilatation, ileus, nematosis intestinalis, and portal venous gas. Previously, we used to say 2A, 2B. And same with stage 3, which is advanced NEC. We have severe apnea, hypotension and shock, DIC, neutropenia. So stage 3 neck has a very high mortality rate. And we get ascites and pneumoperitoneum as well in these cases. So most of the stage 3 either need drain or laparotomy. And stage 2, you need to monitor them closely and treat appropriately so they don't go into stage 3. We have something called fulminant neck, where within a period of 12 to 24 hours, the baby starts getting rapid abdominal distension, typical nematosis, and goes into shock. So before we can do anything, baby passes away.